Hi, welcome back everyone for lecture number 2. Hopefully you all had a great lunch, got a little bit of time to relax. Before we get going, are there any questions? All right, good, a little good on chat. All right, well, in that case, we'll get going. We'll pick up where we left off. I do want to talk a little bit about how we approach the general management of dysrhythmias. And so dysrhythmias, we can generally think of them as falling into a few different categories. First of all, there's a category of dysrhythmias where the patient is not being adversely affected. And so it's just watch, wait, assess, and monitor. Okay, there are some dysrhythmias that are, for all practical intents and purposes, not causing substantial symptoms. And then there are other types of dysrhythmias that do cause some degree of compromise. And so that's where I want to focus. And the initial management of these dysrhythmias, these symptomatic or potentially problematic dysrhythmias, really fall into 3 major categories. They're either too fast, they're too slow, or they're too dead. Those are the 3 major categories of dysrhythmias: too fast, too slow, and too dead. And when it comes to treating them, there are algorithms. The American Heart Association has published algorithms, and the current algorithms were published toward the end of 2020. And so those are the algorithms I'm going to be using. And I want to emphasize the algorithms in the textbook are still using the 2015 guidelines because they are so new. There are some minor changes that have been made, and even some different doses. So you want to be sure that you are using the most current algorithms. I have included them for you all in in Canvas. And so I'm just going to briefly go over them. And if you have your ACLS textbook, which you should, because that is a required book for the cardiology class that'll be occurring here in a few weeks, the cards in that textbook are a mandatory part of what you need to have on you when you are working through patient scenarios and situations. So it would really be helpful for you all to get those cards and access them early now and get used to them and understand how to use them. So I'm going to go over those real quick, and then we will get through some of the dysrhythmias that I want to talk about today. All right, these are again in Canvas for you all. All right, so this is the first of the major algorithms, and I'm doing this in no particular order. And this is the symptomatic bradycardia algorithm. So the way that you need to approach these is you need to start at the top and work your way through every box. The way that this works is these orange colored boxes are the problem that you are wanting to solve. So this is the bradycardia, all right? This is the problem, right? Assess appropriateness for clinical condition. That means, is this a bradycardia that's causing problems? Typically, the heart rate will be less than 50 per minute, all right? So if it's greater than 50, you're generally not going to be treating the bradycardia itself, all right? And then you move down. Green boxes are interventions. These are things that you need to do. All right, so maintain airway patency, give them oxygen if they need it, get them on a cardiac monitor, monitor their blood pressure, pulse oximetry, get an IV in place, get a 12 lead, but don't delay therapy if they're very unstable, and then consider possible causes, or what we call the differential diagnoses. Anything in red is a critical decision point. These are the most critical decisions you have to make with these patients. So, is this slow rhythm, and it doesn't matter what the exact rhythm is, if it is too slow and it is causing problems, it falls under this algorithm that we're looking at, the symptomatic bradycardia. All right. So this red polygon here, hexagonal hexagon here, contains the most critical decision point. Is this stable or unstable? That's what this is asking. And you go down the list. Is this causing hypotension? Yes or no? Is it causing acutely altered mental status? Yes or no? Signs of shock? Yes or no? Ischemic chest discomfort? Yes or no? Or signs and symptoms of acute heart failure? Yes or no? If you answer yes to any of these questions, this is an unstable patient and you need to treat them as such. If no, they're not hypotensive, they don't have altered mental status, they don't have signs of shock, they don't have ischemic chest discomfort, they don't have acute heart failure, then you monitor and observe them. If yes, the initial treatment is atropine. Doesn't matter if it is some junctional rhythm or some heart block or sinus bradycardia. Doesn't matter the exact rhythm. If it is slow and unstable, everybody gets atropine. And if atropine does not work, then you have three interventions to choose from. You can begin pacing, you can start a dopamine drip, or you can start an epinephrine drip, or you might have to do a combination of things. All right. And then move down, expert consultation. What does that mean? Transport them to appropriate facility or call medical direction if you're not getting the results that you want with these primary interventions. And then transvenous pacemaking is something that we cannot do out in the field. All right. So it's fairly straightforward when you have an unstable bradycardic dysrhythmia. Give them atropine, 1 milligram every 3 to 5 minutes to a maximum of 3 milligrams. If they do not respond to atropine, then you can pace and or dopamine or epinephrine infusions. And we're going to teach you how to pace and all of that. Okay. We're going to teach you that. So don't worry about that. I just want you to get used to this. And we run into this time and time again where students go into scenarios and they just completely fall apart. And it is just fundamentally, they have all the tools to negotiate that scenario, and they just don't look at the algorithm and go, okay, this is a problem I want to solve. Let me follow my algorithm down systematically, step by step by step. At this point in time, this is not the time for you to try to memorize all this and to try to do high order clinical decision making. You all just don't have the experience yet. So that's why we're going to say, go to the cards, follow it down step by step by step. There is more nuance here, right? And you may run into providers that'll be like, well, I don't give atropine for this particular dysrhythmia, and I do this. That is nuance that will come later. Right now, we need to get the foundation. So you need to follow these algorithms. All right, so this is for rhythms that are too slow. We call symptomatic bradycardia. The next algorithm I want to briefly talk about is the most complex in many ways, and these are symptomatic tachycardias. These are rhythms that are too fast. All right, again, is this appropriate for clinical condition? Typically, the heart rate has to be greater than 150. If it's less than 150, it's more than likely some sort of sinus tachycardia, and you do not treat sinus tachycardia with this algorithm. This has to be a tachycardic rhythm where the sinus node is not in control. And typically, when the heart rate exceeds 150 per minute for prolonged or sustained periods of time in adult patients, the sinus node is not really running the show. All right, that's a general rule of thumb. So move on down, identify and treat underlying causes, just like with the bradycardia, maintain airway, give them oxygen if they need it, get them on a cardiac monitor, get a set of vital signs, get an IV, get a 12 lead if available. And then you move down to the critical decision points. So the critical decision point with tachycardias is just like bradycardias. Is this a stable or an unstable patient? So do they have hypotension, altered mental status, signs of shock, ischemic chest discomfort, acute heart failure? yes to any of those questions, you move to this green box here, synchronized cardioversion. All unstable tachycardias will get cardioverted, and we will talk about what cardioversion is tomorrow in the lab when you start learning how to do some of these electrical therapies. All right. All unstable tachycardias will get cardioverted. Doesn't matter if it's wide or narrow, above the heart, above the ventricles, in the ventricles, doesn't matter. If it is rapid and unstable, they get electrical therapy. However, if you answer no to all these questions, then you need to answer one more question. And that question is the QRS complex wide or narrow? And the threshold that we use is 0.12 seconds. So I told you the normal QRS is less than 0.1 seconds, but for the purposes of diagnosing a wide versus a narrow complex tachycardia in a clinical situation, we use 0.12 seconds. That's 3 small boxes. If it is a narrow complex tachycardia, so the QRSs are less than 0.12 seconds, you start with vagal maneuvers if the rhythm is regular, adenosine if the rhythm is regular. If that doesn't work, consider beta blockers or calcium channel blockers, and then expert consultation, i.e. rapidly transport them to definitive care. If the QRS complex is wider than 0.12, you can consider adenosine only if it is a regular rhythm that is monomorphic. That means the complexes all look the same. So if the QRS is wide, but it is regular and all the complexes look the same, you can give adenosine. Otherwise, you're going to look at an anti-dysrhythmic infusion. So you see this box here. These are the 3 major anti-dysrhythmics we can choose: procainamide, amiodarone, or sotalol. And of course, lidocaine might also be considered for a wide, complex, stable tachycardia. But again, these are the primary agents that we go for. All right. Is everybody okay with the bradycardia and the tachycardia algorithm? All right.
Yes.
Cool. It's really that easy. Unfortunately, when we get into scenarios, for whatever reason, there's a tendency for people not to look at their cars, not to follow them, and they just completely go crazy. And so we'll be calling you out on that stuff as we get further along in the paramedic program, trying to get you comfortable with these algorithms. So with that in mind, now what I want to do is I want to start talking about some of the dysrhythmias. And I'm more or less going to follow along with how it's presented in the textbook. And the textbook actually does a pretty good job of explaining these and giving you some examples of rhythm strips. So I'm going to start, where I'm going to start in your textbook starts on page 992. And that's what we're going to cover today. We're going to cover the so-called supraventricular or dysrhythmias that are from above the ventricles. So I'm going to go into the iPad and let me share that with you all. So now we know what the sinus rhythms look like. Let's move in and talk about abnormal rhythms. There we go. Okay, so we're going to be talking about atrial dysrhythmias. So these are dysrhythmias that involve or come from the atria, the top part of the heart. And then we're also going to talk about junctional dysrhythmias. And these are dysrhythmias that come from the AV junction and the AV junction, the AV node, the bundle of His. All right. And both atrial and junctional dysrhythmias are above the ventricles. They sit on top of the ventricles. And so these are dysrhythmias that occur above the ventricles. All right. So the first one that I'm going to talk about is something called sinus arrhythmia or sinus dysrhythmia. And this is almost always a normal variation of a sinus rhythm. And this is due to increased and decreased vagal tone with breathing. Typically in young, healthy patients, as they inhale and exhale, that can put pressure on the vagus nerve, and you can get increasing and decreasing vagal stimulation. When the vagal stimulation increases, the heart rate will decrease. And then when the vagal tone decreases, the heart rate will increase. And so what you see is a pattern. So you'll see an irregular rhythm, but you'll have P waves, you'll have QRS complexes, and you'll have T waves. But what will happen is you'll see a pattern of irregularity where the rate is a little faster. So you can see these first three complexes, the rate is faster, and then the rate becomes slower here. And then you see the rate increases here. So you have a pattern of increasing rate, decreasing rate, increasing rate that corresponds with the patient's respiratory pattern. And this, again, is just a normal, typically a normal variation. You can see it in special situations, like if somebody has a really bad like tension pneumothorax or tamponade, sometimes the breathing can impact the heart rate in those situations. And so you might see it in the setting of like a tamponade or a pneumothorax, a tension pneumothorax. But in a person that's not really having any cardiovascular complaints or any history, this is typically what you're seeing. It's just increasing, decreasing vagal tone. Generally, it's just a watch, monitor, assess them for any other issues, but generally it's a fairly benign finding. So that's sinus dysrhythmia or sinus arrhythmia. So the next thing I want to talk about is something referred to as a PAC. And a PAC belongs to a category of problems known as premature complexes. And so what a premature complex is where you have an area of the heart that is what we call ectopic. So an area of the heart becomes ectopic. It becomes, it can be ischemic or poisoned by a drug or injured, and it gets a little angry and it begins firing on its own. So it experiences increased automaticity and it begins firing on its own. And what happens is that ectopic area fires too early. And that's why we call it a premature complex. And this, when this occurs in the atria, we call this a premature atrial complex or a PAC. If it involves the junction, the AV junction, so the AV node and the bundle of His, we call this a PJC, a premature junctional complex. And if it happens in the ventricles begin depolarizing on their own. We call this a PVC, a premature ventricular complex. And the classic thing we see in all premature complexes is the complex starts closer to the T wave than the normal complexes. All right. It's premature, so it's closer to the T wave. And the closer it gets to the T wave, the more problematic it can be because of that R on T phenomena that we talked about involving the absolute refractory period. All right. And these complexes are also associated with something known as a non-compensatory pause. So after the complex, there will be a brief pause before going back into the underlying rhythm. All right. So that's the characteristics of all premature complexes. So let's zoom in here and let's take a look at these PACs, premature atrial complexes. All right. So what you will see is you will see your underlying rhythm. So here's the P wave, here's the QRS, and here's the T, right? And so you see that the normal underlying rhythm appears to be some sort of sinus rhythm, right? And so I've got a P wave here, I've got a QRS and a T wave, and look right here. So this is a P wave, but do you see how that P wave is closer to the T wave than all of the other P waves? You guys see that there? That P wave is closer, and the P wave looks different. It looks different, much different than all of the other P waves because it's not coming from the SA node. It's coming from another area in the atria. So that's why the P wave morphology looks different. So you got the P, then you've got the QRS, and then you see I have a brief pause here where there are no P waves, and you can see that it is longer than the pause that we see on the normally conducted complexes, right? But it's not long enough to account for an entire PQRST. And that is what we call the P to P interval. So if I go from one normal P wave to another normal P wave, this interval here, the P to P interval, if this interval here is shorter than that interval, which it is, we call that a non-compensatory pause. All right. So the complex is occurring early. The P wave on the PAC is going to look different. And it may indicate underlying problems, but oftentimes isolated PACs, which this is a PAC. So this is a sinus rhythm with a PAC, tend to be fairly benign. But certain things like hypoxia and ischemia can increase the chance that you have lots of PACs or premature complexes in general. All right, so generally, if we have PACs, you just want to monitor the patient closely. You want to rule out and treat potential causes. And the primary causes are what we call the H's and T's. These are the primary differentials. And so some of the H's that you want to think about: hypoxia, hydrogen ions, so acidosis, hypo and hyperthermia. All right. Some of the T's you want to think about: tension pneumothorax, a thrombosis, that's a clot, right? Like a clot in a coronary artery or clot in the lung, for example. Toxins, trauma. All right. Another H, hypoglycemia. Throw that in there. Another H, hypo and hyperkalemia. All right. So again, these are just things you want to think about. Could any of these be accounting for what we're seeing? So those are PACs. Now there is another issue that can occur, and it is something referred to as wandering atrial pacemaker, or WAP. That I think in contemporary times may take on a different meaning, but in the context of electrophysiology, it means wandering atrial pacemaker. And this is a group of disorders that indicates possible dysfunction of the SA node. And so what happens is the pacemaker site alternates from the SA node to the AV junction. And so what's going to happen is you're going to have P waves that are going to appear upright, and P waves that may appear flat, and P waves that even may appear inverted. And so what's going to happen is the P wave morphology is going to change. And you may have a regular rhythm or an irregular rhythm. So when we look at this here, you can see that there's a P wave here, and a P wave here, a P wave here, and a P wave here, a P wave here, a P and a P and a P. And you can see that the morphology of the P waves is changing. It's very subtle in this particular example. But you can see that the morphology is changing a little bit. In this case, it's a little irregular. It may be regular as well. Sometimes it can be very pronounced where, you know, you might have a P wave that looks like this. And then you'll have a P wave that looks like this. And then maybe a P wave that looks like this. And then another P wave that looks like this. And so you can see the P wave morphology is just kind of all over the place here. And that's what we call wandering atrial pacemaker. The pacemaker site it's basically playing hot potato with itself. All right. If the rate is adequate with wandering atrial pacemaker, just monitor the patient, rule out and treat any underlying causes. Think of the H's and T's. The next dysrhythmia I want to talk about is atrial flutter. So atrial flutter is caused by an ectopic focus. And ectopic just means out of place. When you hear that term ectopic, it means out of, like an ectopic pregnancy is an out of place pregnancy. So ectopic focus or ectopic foci are just areas, foci being plural and focus being singular, is just an area of the heart that has too much automaticity, and it is firing on its own and out of place, right? And that could be could cause a premature complex, and it can cause other things. So what happens in atrial flutter is an ectopic focus above the ventricles begins rapidly firing in the atria. All right. Now, if the AV junction is doing its job, it can block most of those impulses. And so what you get, and I'll show you some examples, is you get lots of P waves. And so you get an underlying pattern that kind of looks like this, and this is referred to as a sawtooth pattern. And that's classically seen. A sawtooth P wave pattern is classically seen in atrial flutter. All right. In many cases, if the AV junction's working, it can block most of those out, and the underlying ventricular rate will be controlled. All right. Sometimes it can't block those out, and then the more of these P waves that get through, the more R waves, the more QRSs you're getting. And if every one of them makes it through, the underlying ventricular rate can get incredibly rapid. All right. May get so fast that it could require electrical or pharmacological therapy to reduce that rate. The ventricular rhythm with atrial flutter is often regular. And you see the classic flutter or sawtooth wave pattern. And let's take a look at that here. So this is a classic example of an atrial flutter. Now, when it comes to A-flutter or atrial flutter, and a related rhythm that we're going to talk about next called atrial fibrillation or A-fib, there is another add-on that we need to do, and that is called the response. And so if somebody has atrial flutter or atrial fibrillation, we need to identify the underlying ventricular response. So here you can see you've got all these P waves here, right? You've got this flutter, this sawtooth pattern. But what's happening is the AV junction is blocking out most of these. So this one's getting blocked, this one's getting blocked, this one's getting blocked, this one's getting blocked, right? So you actually have 4 P waves to every QRS complex, all right? And so this is what we call a 4-to-1 conduction pattern. It could be 3-to-1 or 2-to-1 or 1-to-1 even. And when that happens, when the junction's not able to block these out, the rate gets faster and faster. And if the rate in atrial flutter or atrial fibrillation goes above 100, we say that there is a rapid ventricular response, or RVR. If the rate is under 100, we say that there is a controlled response. And so here the rate 1, 2, 3, 4, 5, 6, 7. So the underlying ventricular rate, 7 times 10 is 70. The rhythm is regular. So this is an atrial flutter with a controlled response as opposed to rapid response. All right. Now, another related dysrhythmia is something called atrial fibrillation. Atrial fibrillation is incredibly common, incredibly common. So in atrial fibrillation, what happens is, unlike with atrial flutter, where just one area is depolarizing on its own, in atrial fibrillation, you have multiple ectopic foci firing. So you have multiple areas in the atria firing at the same time. And this will create what's known as an irregularly irregular rhythm. So anytime you have an irregularly irregular rhythm, right, you want to be thinking about atrial fibrillation. And essentially what happens is the atria begin to quiver. So the top part of the heart begins to quiver. It's very disorganized. And the atria are not able to contract and pump blood effectively into the ventricles. And so what can happen is you can lose some cardiac output, because some of your cardiac output depends on the atria preloading the ventricles with blood. But you have lost a preload, and you can lose up to like 30% of your cardiac output when your atria quit working. In addition to this, because blood can start pooling in the atria, specifically in an area of the left atrium known as the left atrial appendage, it's kind of a flap that can fill up with blood. Blood clots can form, and those blood clots can become dislodged, and then they will have a tendency to go to the brain. So atrial fibrillation, one of the big risk factors of atrial fibrillation is a risk of stroke. These patients are at high risk for having stroke. So you have a chaotic and wavy baseline. So if you look at this baseline, you see how you can't really identify any specific P waves. It's very disorganized and chaotic, whereas flutter, you could identify P waves, right? You had the sawtooth pattern. Here with atrial fibrillation, it is very disorganized and chaotic, and you can see that the R to R interval is incredibly irregular, and there is no pattern to it. So that interval is different from this interval, is different from this interval, is different from this interval. So it is the ventricular, the ventricular response is completely chaotic. All right. Now, just like atrial flutter, if the AV junction's doing its job, it can block out a lot of this stuff, and the rate, the ventricular rate, will be less than 100. And just like with atrial flutter, if the ventricular rate is less than 100, we say that this patient has atrial fibrillation with a controlled response. All right. People in atrial fibrillation tend to be on anticoagulants like Coumadin or warfarin. And now, of course, this is being overtaken by the DOACs, the direct-acting oral anticoagulants like dabigatran and other agents. Sometimes they are also placed on a medication called digoxin. Remember, we talked about that pharmacology as a cardiac glycoside. It is a negative chronotrope, so it decreases heart rate, but it is a positive inotrope, increases contractility. Unfortunately, digoxin, right, has a fairly narrow therapeutic index, and it risk for toxicity can be high, particularly if there are any electrolyte imbalances, specifically potassium imbalances. So digoxin is a tough one to work with, as well as Coumadin. So we don't see digoxin used quite as much as it once was. All right. It can be difficult to treat. And if somebody has been in atrial fibrillation for more than 24 hours, converting this back into a sinus rhythm in the field is not likely indicated unless the underlying rate is so rapid that we have to get the rate down because the patient is unstable. That's a different situation. But generally speaking, if they're not unstable, we do not want to convert atrial fibrillation out in the field because the risk of dislodging a clot. All right. So again, increase the risk of stroke. This is a common rhythm in congestive heart failure patients, and atrial fibrillation is very common in general. Underneath, I have another example of atrial fibrillation, but this is very different from the one above. So here is a marker. So that's 3 seconds. So here's a 6-second strip. So you can see you've got this very chaotic baseline, and you've got a very irregular rhythm, but let's see the rate. So I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, right? So I have 18 R waves in a 6-second strip. 18 times 10 gives me 180. So the underlying heart rate is 180. So it's greater than 100. And so we would say that this patient has atrial fibrillation with RVR, with a rapid ventricular response, as opposed to the controlled response that we see up here. All right. And then that brings us to yet another term, and this is a broad term, but it is something referred to as SVT, or supraventricular tachycardia. Now, supraventricular tachycardia is a broad term for a group of tachycardic problems. All right. So SVT is technically any tachycardia that is coming from above the ventricles. So technically, this right here, A-fib with RVR, is a form of SVT, but because we can clearly see the underlying atrial fibrillation, we call it A-fib with RVR. But if we couldn't, like if the rate was so rapid, we couldn't tell where it's coming from, we would call it SVT. So SVT is a catch-all term for any narrow QRS complex tachycardia. Sinus tachycardia is excluded from this, however. So this is any narrow QRS complex tachycardia. So the QRS duration is less than 0.12 seconds, or 3 millimeters. And we don't know exactly where it's coming from. We just know the QRSs are narrow, so it's coming from somewhere above the ventricles. That's what SVT is. So it's a broad term for a group of tachycardic problems where the ectopic foci or focus is in the atria somewhere. It's above the ventricles, but it's not the SA node. Okay. And this can include the AV junction as well. Okay. So typically, SVT presents with rates above 150 and have narrow QRS complexes in the absence of something called a bundle branch block. And we'll talk about bundle branch blocks in more detail later on. SVT is often regular unless there is atrial fibrillation. So anytime you have an irregular SVT, you need to suspect atrial fibrillation. And do not treat sinus tachycardia like SVT, because the sinus node is in control, right? In SVT, the sinus node is not in control, but we just don't exactly know where it's coming from, right? So SVT is this catch-all term. So let me give you a couple of examples. So A-fib with RVR is technically a form of SVT, but you can clearly identify the A-fib, so it's better to call this A-fib with RVR. A-flutter with RVR is also technically a form of SVT. So here I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, right? So I've got 11 times 10 equals 110. That's technically SVT, but because you can clearly see these flutter wave pattern here, you would not call this SVT. You would call this A-flutter with RVR, rapid ventricular response. Okay. If, when you put your patient on the monitor, you see the SVT rapidly begin and end, so it comes on quickly and terminates quickly, this is something that we refer to as PSVT, or paroxysmal, right? Paroxysm is something that comes on rapidly, like a paroxysm of coughing. There's a coughing that occurs suddenly. So here I have a sinus rhythm, right? So I've got a P wave, I've got a QRS, and I've got a T wave. I've got a P, QRS, and T. And so I can see I have some sort of sinus rhythm, and then bam, look at this. All of a sudden I have a very rapid rhythm that develops, and you can see the QRS complex is narrow, right? And it's so fast that I don't really know what this is here. Are these multiple P waves, or I don't know. It's so fast. I don't really know what's going on. I just know that it is rapid and narrow. And so this is SVT. And because I'm seeing it occur all of a sudden in front of me, we call that PSVT. Likewise, here's just a strip of sustained SVT. So this is just somebody who is in SVT and it's not going away. So you see the QRS complex is narrow. It looks regular and it's very rapid. The rate is about 180. I don't know. I can't, it's so fast. Is that a P wave buried in the T wave there? Maybe is that a little P wave there? I don't really know. It's just so fast. I don't know where it's coming from, other than I know the QRS complex is narrow. So it's coming from somewhere above the ventricles. I don't know where. And so I'm going to call it SVT until I can get additional information. All right, everybody okay with that so far? All right, so let's talk about some special considerations next. So there are many specific causes of supraventricular tachycardias. And I'm not going to go into them in incredible detail today, but I do want to talk about one major cause, and this is one of the most common causes, and this is a concept known as reentry. And with reentry, a lot of times what you can get is you can get what's known as an accessory pathway. So an accessory pathway is an abnormal conduction pathway. So remember we talked about the three major conduction pathways, the anterior, medial, posterior. The median was the Winky-Bach pathway. The anterior is also known as Bachman's bundle. But in some patients, and these tend to be genetic, they can have an additional pathway that is abnormal. And it allows, and so here I have a picture of this. So here is the, let me do a different color. Here is the SA node, and here is the AV junction. And you see in purple here, I have an additional pathway that is bypassing the AV junction. So what happens is the depolarization can travel through that pathway, bypass, because remember, it normally will get held up at the AV junction. But in this case, it's bypassing it. And then what happens is it can retrograde, it can go back up through the junction and back into the atria, and then go back around, depolarize the ventricles, come back up, go back through, go back around, depolarize the ventricles, and it becomes a vicious cycle that goes faster and faster and faster and spins out of control. And these are collectively referred to as pre-excitation syndromes. These are people that are more prone to developing supraventricular tachycardia. Okay. And some examples include Longenong-Levine or LGL syndrome and Wolff-Parkinson's-White or WPW syndrome. And these different pathways have different names. For example, with Wolff-Parkinson's-White syndrome, the abnormal accessory pathway is, let's see, what is it? Bundle of Kent, I believe, is the name of the accessory pathway that we see in Wolff-Parkinson's-White syndrome. And we will talk about Wolff-Parkinson's-White or WPW in a little more detail a little later on in this course. But there are implications for treating tachycardias, because if somebody has a pre-excitation syndrome, what can happen is you might want to give them a drug like adenosine or a beta blocker or a calcium channel blocker that slows conduction or blocks conduction through the AV node. And in people without these accessory pathways, that may actually work. But what you're doing in somebody that has an accessory pathway is you are now pushing all those impulses through that accessory pathway, and you may actually make the situation worse. And you could potentially even cause a patient to go into a cardiac arrest rhythm. And Wolff-Parkinson's-White in particular is fairly common. In fact, the last two paramedic classes, last three paramedic classes, each of those classes had a person with Wolff-Parkinson's-White. In fact, one of them actually had to have what's known as an ablation, and we'll talk about what that is, but it's a procedure that either burns or freezes or sometimes uses radio frequency to try to destroy that accessory pathway, because that person was having problems with developing supraventricular tachycardia. But treating it pharmacologically with AV nodal blocking agents may make it worse, right? And so you may give somebody a beta blocker or calcium channel blocker, right, thinking you're doing the right thing, and you could actually make it worse, right? That's why I mention these, because if you see this in somebody's history, you need to be very cautious about giving them drugs that slow conduction through the AV node. All right. Let me zoom out on that there. Okay, moving right along. So what does Wolff-Parkinson's-White look like? Well, funny you should ask. So typically what you will see is something called a delta wave. So you will see a QRS that is wider than normal, and you will have a slurring on the initial part of the QRS complex. And imagine that you could put a little triangle in there. See how I just drew a little triangle in there? And remember, a triangle is a capital Greek delta. And that's actually where the term delta wave comes from, is it looks like you could put a little triangle in there. And that slurring is known as a delta wave. And that is a classical finding that strongly suggests somebody has Wolff-Parkinson's-White disorder. All right. And then when they develop SVT, because the QRS is wide, this may resemble ventricular tachycardia. But if we look at this closely, right, look at lead 2 here. See that slurring there. See that slurring there. Got some slurring there and there. Right, you can clearly see delta waves. You can see delta waves in lead 3 here as well. Just putting little triangles in there. So this clearly, or this strongly suggests that this is somebody with Wolff-Parkinson's-White disorder, which in fact it is. All right. So before we move on, any questions? Let me get my video going here. Any questions over anything so far? Okay, well, in that case, we'll continue moving on. So the next thing I want to talk about is something called sinus arrest. And what sinus arrest is where the sinus node quits working and you have a sustained pause. And to call something sinus arrest, the pause has to meet or exceed the P to P interval, right? So the beginning of one PQRST to the beginning of another PQRST. So that interval here, if the pause that we see is longer than that interval, then we call that sinus arrest. So you see that the sinus node just quit working, you have a prolonged pause, and then you go back into the underlying rhythm. That's called sinus arrest. And that is indicative of a failing SA node. Fails to fire, causes a sustained pause. All right. And you have to at least have one missed PQRST complex. If you see sinus arrest occurring with other things, like if you see this with a wandering atrial pacemaker, okay, then we would call this another disorder called sick sinus syndrome. Just means the sinus node is even sicker. And sometimes what you can get is you can get a off branch or a variety of sick sinus syndrome called Tachycardia syndrome, where the heart rate alternates between a sinus tach with these pauses, and then sinus brady with these pauses and these periods of arrest, and that's called Tachycardia syndrome. Again, this is a sinus node that is on the way out. Generally, it's become ischemic, maybe poisoned. Here's a situation where you have a sustained period of sinus arrest, and then you have an escape complex. Because there's no P wave, this is actually coming from the junction. We'll talk about that here in just a few minutes. And then that kind of resets things in a sense, and the person goes back into the underlying sinus rhythm. So what are we concerned about here with substantial sinus arrest? Well, we're worried about slow heart rates, right? If the heart rate gets too low and the patient becomes symptomatic or unstable, we may need to take action in order to increase the heart rate, right? So we may need to give them atropine. And if that doesn't work, then we need to maybe look at pacing, transcutaneous pacing, or dopamine, or an epi-drip following ACLS guidelines. All right, so that's sinus arrest. You know what? Let's take a little break. Let's take a quick break before we finish up talking about the junctional dysrhythmias. So let me stop here. Let's 13:56. So I'll see you all at 14:05. I'll see you at 2:05. Let's just take a little break. All right, welcome back, everyone. Before we get going with the last part of the lecture, and this will be the last bit of lecturing that we'll do today, are there any questions before I move on? Okay. All right. So now what I'm going to do is we've primarily been talking about problems in the atria. So let's talk about problems the very bottom part of the atria in the junction. So let's do that now. So let me go ahead and share. Looks good. Stop the video. All right. So let's talk about the junction. So first, just like PACs, premature atrial complexes, you can get a complex, a premature complex that comes from the junction, and this would be called a premature junctional complex. And PJCs look very similar to PACs, except PJCs tend to have no P wave. So if you have no P wave and a narrow QRS complex, followed by a T wave and a non-compensatory pause, that would be a PJC, or you may have an inverted P wave. So no P wave or an inverted P wave are classic findings that we see with premature junctional complexes. And if you reference your textbook, page 1002, there is a pretty good rhythm strip of a sinus rhythm with a PJC. In this particular one, it's circled in red, and there is a sinus rhythm with P waves, and then you see a complex with no P wave, and then you see a little pause after it, and then you go back into that sinus rhythm. So that is a PJC. Now, in addition to that, what can happen is if the SA node fails as a primary pacemaker and the junction is functioning properly, it can take over. But remember, its intrinsic automaticity is lower than the SA node, and so it can take over, but it will fire slower than the SA node. So typical rate of a junctional rhythm, or these are sometimes known as junctional escape rhythms, means the same thing. All right. The typical rate is between 40 to 60. And oftentimes there will be no P waves, or if there are P waves, the P waves will be inverted. And that's because what you can get is if it's very high in the junction, so very high in the junction, close to the atria. So if that part of the junction is taking over and it's firing, what can happen is, I'll draw a little picture here. Here's the SA node. And then here's the AV junction. What can happen is if this upper part of the junction is taking over, it begins firing. And what you can get is you can get retrograde right? As it fires, you can get a retrograde impulse moving in the opposite direction. And remember, with an ECG, if you are moving toward the positive electrode, the complex will be upright. But in this case, right, this is moving in the opposite. Normally, it will move in this direction, but in this case, it's moving in the opposite direction. And so it's moving toward the negative electrode. And what will happen is the P wave will become inverted. Now, if it is happening far down in the junction, where you don't get that retrograde depolarization, so it just depolarizes down in the ventricles, you will have no P wave and a narrow QRS. So that's what we see, and let me enlarge here. That's what we see in this first example here. You can see there are no P waves here, right? So there are a lack of P waves, but the underlying rhythm is regular and the rate is 40, right? So I've got a rate of 40, no P waves. I've got a normal, so P to R interval is NA in this case, but I've got a normal QRS complex, right? It's narrow. So a narrow QRS complex tells us that whatever the problem is, it's coming from above the ventricles. All right. And a slow rate. And so put all that together, and that is a junctional escape rhythm. And in this case, it does not have P waves, but you could easily have a junctional escape rhythm that does have P waves, because you're getting that retrograde conduction, such as the case down below here. So I've got a rate of 1, 2, 3, 4. So I have a rate of 40. I've got a regular rhythm, right? I have P waves, but they are inverted. Do you see that there? They're inverted because I'm getting that retrograde conduction. So inverted P waves, and typically you will have a very short, you'll have a short P to R interval. So inverted P waves is a short P to R interval and a narrow QRS. This is also a junctional escape rhythm, right? So these are two examples of a junctional escape rhythm. All right. Now, occasionally what can happen is the automaticity of the junction may increase. Maybe this person was given atropine, right? So maybe atropine was administered, and you get an increase in the automaticity of the junction. So the normal rate for the junction is 40 to 60, and that's what we call a junctional escape rhythm. But if the automaticity of the junction is abnormally high and the rate is 60 to 100, we call that an accelerated junctional rhythm. So when you have increased automaticity at the AV junction, this will increase the rate to the normal range. And so if you have a junctional rhythm with a rate of 60 to 100, we call that an accelerated junctional rhythm. So you see here, I have these inverted P's here that are very close to the QRSs. So this is a junctional rhythm, right? But the rate is 1, 2, 3, 4, 5, 6, 7, 8. So the rate is 80. So that we'd call this an accelerated junctional. And then if the rate is above 100, we would call this junctional tachycardia. So 40 to 60 is a regular junctional rhythm or junctional escape rhythm. 60 to 100 is accelerated junctional rhythm. And then above 100 is junctional tachycardia. Technically, junctional tachycardia is a form of SVT. But when we look at this, you can clearly see these inverted P waves. So even though this is technically SVT, we have enough information to determine where the SVT is coming from. And so the most accurate name for what we see is junctional tachycardia here. So the rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So the rate here is 120. The rhythm is regular. There is a P for every QRS and a QRS for every P, but you have inverted P waves. The QRS is narrow. So yeah, we're dealing with a junctional tachycardia here. All right.
Yeah, Chris.
Yes.
So the book has the same junction with tachycardia with P wave just right after the QRS. I don't know. Do you have an example of that?
I don't.
No.
But it can
You
happen.
might explain that. Okay.
Yeah, same thing, right? So, right, here's the SA node, right? And here's the AV junction right here. And so you can get kind of these weird things that can happen where the ventricles can depolarize, right? So the ventricles depolarize. And so while the ventricles are depolarizing, so let me draw the right bundle branch and the left bundle branch here. So what's happening is while the ventricles are maybe depolarizing, you get another signal that's generated from up high here, right? So it occurs up high in the junction, and it moves up into the atria. So that causes the P wave to appear downward, but that's occurring before or toward the end of depolarization of the ventricles, right? So this is occurring here. So you got the QRS occurring, right? You got the QRS occurring, and then the junction fires off. And so you get that inverted P wave. Does that make sense?
Yes, sir.
Cool. All right. Good question, though. Yeah. Thanks for asking. All right. So just to talk a little bit about treating junctional rhythms. Typically, if the rate is low and the patient's symptomatic, treat this as a symptomatic bradycardia, like we talked about earlier. Note the AHA algorithms. If it is a super fast, if it's an SVT, rates greater than 150, patients unstable, treated as a symptomatic tachycardia. But when it comes to escape rhythms in general, because you also have ventricular escape rhythms, but we'll talk about those later, not today. You want to avoid agents that suppress nodal tissues, because you don't want to wipe that escape rhythm out, right? So if you have a junctional escape rhythm and you get some agent like a beta blocker or something like that, you could potentially shut the AV junction off, and then you may lose that escape rhythm and your patient could get worse. So you want to be real careful there. All right. So that is all of the material I want to go through today. I think that's plenty. So what I want to do before we conclude is I just want to make sure that everybody understands that there is some homework that's going to be due, and you'll have the rest of the day to work on that. So there is a quiz, and then there is your first homework assignment. So let me just do a quick screen share, make sure everybody's on the same page, and then I'll let you all work on the homework tonight, turn it in, and then we will go over that in the morning. And then you'll have more homework and you'll just be practicing this stuff over and over and over again. All right, so We go down to your assignments. So you have your first set of homework, SA and AV node problem set. So these are about a dozen, I think, a dozen different dysrhythmias. And so what you need to do is download this file, and then you just need to interpret that, right? What's a rate? What's a rhythm? P for every QRS, QRS for every P, P to R interval, QRS, interpretation. Interpret those rhythms, turn them in, and then we will go over them tomorrow. In addition to that, you will have a quiz that's due. So if we go to quizzes here, you will see we've got a quiz here, quiz 1. It's due by 8 in the morning tomorrow. So make sure that you complete the quiz, you complete the homework, get that turned in. And then the last thing that you're going to want to do is there's another file that you're going to need to download, and you're going to need that for lab tomorrow. And let me show you where that is. Under assignments, the very top, right underneath the homework is something called live 12-lead performance and assessment exercise, lab exercise. So click on this, download and print off the Word document here, and then bring that with you to class tomorrow. And you will we'll be doing 12-lead ECGs on each other and rhythm strips and printing them off. And then you will be attaching those to this, and you will be identifying different things, and you'll be doing some Einthoven's triangle work and whatnot. And then you will take a picture of that and attach that to Canvas as your assignment for tomorrow morning. So you've got the homework assignment that's due by midnight. You've got quiz 1 that's due by 8 in the morning. And then you want to print off the 12-lead lab exercise, so you have that available tomorrow with you tomorrow. Any questions? Okay, great. So what I will do is I will see you all at 9 in the morning. I will get in, I'll be in a little early, around 8, to get things set up. And then I'll see all the rest of you at 9 a.m. If you come in a few minutes early, that'd be great, so we can start just before. And we'll do a review of the homework and the quiz, and then roll right into the ECG acquisition. And then we'll take a lunch, and then the afternoon we will be working through atrial and junctional rhythms on the monitors. All right, any questions before we wrap things up? Okay, well then I will leave you all to your homework and your quiz, and I will see you all in the morning. Thank you so much.
Thanks, Chris.
Thank
Thanks,
you.
Chris.
Very
Thanks.
welcome. Well, take care.